Great, thank you so much. We're going to go into detail about concurrent billing. And so the objective at the end of this, you'll have a much better understanding about opportunities to support a sustainable model for addressing health-related social needs and leveraging concurrent billing in that process. Next slide. So my agenda, I'm going to go through the concurrent billing regulations. I'm going to talk about the evidence that support the implementation of a model, or really talk about the role of the transitional care management as the initiating visit, and then give you an example application of the concept of concurrent billing for a person being discharged from the hospital and how that provides significant resources to address the broader whole person care needs. Next slide. So concurrent billing, but essentially concurrent billing allows for a provider to bill for more than one service during a similar episode of care and be compensated for those additional services. And on the left-hand side is a list of services that are approved for concurrent billing. And on the right-hand side are those that are not approved. So I'll take the first one as an example. The first one on the left-hand side, approved for concurrent billing. TCM stands for Transitional Care Management, which was a benefit that began around 2015 to, actually before then, more like 2012, to provide reimbursement for follow-up care for a person that's being discharged from an institutional setting. Transitional Care Management reimburses for post-discharge visits after an acute hospital stay, a SNF stay, or an inpatient behavioral health or mental health hospital. What's approved for concurrent billing is transitional care management and chronic care management. If you're familiar at all with the chronic care management benefit, when that benefit was first established, it did not allow for concurrent billing. So that meant that during the 30-day follow-up post-discharge for transitional care management, you could not be reimbursed for transitional care management and chronic care management concurrently or during the same episode. That has changed. That was actually a significant change to allow transitional care management and chronic care management to occur concurrently. And now with the introduction of the community health integration and principal illness navigation codes, with community health integration allowing for reimbursement to address identified health-related social needs, and principal illness navigation providing reimbursement for providing health navigation for persons who have a serious high-risk condition that can be billed concurrently with transitional care management. In addition, chronic care management can also be billed concurrently with community health integration. So particularly ACOs, accountable care organizations, have increased their utilization of chronic care management, which is a non-face-to-face service to provide coordination of care for persons' medical conditions. So a lot of practices have invested in care management staff to provide chronic care management. The concurrent billing rules allow for those practices to receive reimbursement for chronic care management and address their social needs under community health integration concurrently, so the reimbursement for both could occur during the same episode. However, only one eligible provider can deliver chronic care management and community health integration during the same calendar month. I'll go into a lot more detail. This concept of concurrent billing will be much clearer as I go through the additional slides and the case study example where we'll apply this. Someone put in the chat, is care transitions considered transitional care management? Transitional care management is the benefit, the Medicare benefit that reimburses a eligible provider, Part B provider, for doing the follow-up care during a transition episode, which would be 30 days from an institutional setting. Care transition is often referred to as the activity, where transitional care management is the benefit. So that's the nuance between the two concepts. There are some other requirements for transitional care management, which I'll touch on during the application of the case study. Now, those things not approved for concurrent billing a home health episode of care. So a person who is receiving home health, maybe they have home health initiated as part of their discharge plan, is not eligible for community health integration to address their social needs during a home health episode. So if that person has identified health-related social needs, but also requires home health services, there is a limited social work benefit that is embedded in the all-inclusive episode of care of home health, and that was seen as a duplicate service. And so that's why the home health episode of care is not allowed for concurrent billing, because the social work benefit that's embedded in home health is supposed to be used to address some of those social needs. So if we were to deploy community health integration, it would have to be at the conclusion of any active home health episode of care. And then lastly, hospice, if you're familiar with hospice, that is a Part A benefit. When a person is receiving their Part A hospice benefit, they cannot receive Part B benefits. And so you could not concurrently have that person receiving hospice and Part B community health integration services. And then lastly, hospice also has a limited social work benefit. Well, I won't say limited. It has a social work benefit embedded, and so that should be used to address their social needs. Next slide. So the expected impact, as we think broadly around the strategy on addressing health-related social needs and why leveraging concurrent billing should be part of your overall strategy to support that, I wanted to highlight what the literature and what the data says. Next slide. The most recent and my broadest evaluation that has occurred when looking at the impact of addressing health-related social needs in the Medicare and Medicaid population is the May 2023 Accountable Health Community second evaluation report. There are two evaluation reports, the first and the second. The most recent data is from the second evaluation report, which really had some unexpected findings in the data that is really applicable to this concept of addressing health-related social needs as part of a discharge planning process. Next slide. So there was a statistically significant outcome with the N, or the population, being over 1 million participants in this accountable health community model. And the participants were broadly across the country, where over 1 million people participated. If you're familiar with the accountable health communities model, the participating practices and hospitals screen for health-related social needs as part of their participation. It was a 5-year demonstration that is now completed. During that 5-year demonstration, there was an assistance track where persons who were screened for health-related social needs were also linked with groups that would then provide assistance in addressing their health-related social needs. It was a statistically significant outcome that there was a direct impact on utilization and costs for participants that received assistance with addressing their health-related social needs. Specifically, it showed a reduction in unnecessary ED visits and avoidable ED visits, where there was a statistically significant reduction for both Medicare fee-for-service and Medicaid. And so that data bore out. Next slide. So one of the things that was also really significant, if you look at this slide, first starting on the left-hand side, where we're looking at the impact. So the impact of unplanned readmissions was greatest amongst Medicare fee-for-service, non-white and/or Hispanic participants. So you see really a huge impact on unplanned readmissions. So if we're looking at a strategy on screening for social needs and whether or not we should deploy interventions to address social needs, the data looking at an N, or a data pool or population pool of over 1 million participants, that there was a significant impact on unplanned readmissions that was most significant for Medicare fee-for-service beneficiaries that were non-white and/or Hispanic. On the right-hand side, it also showed that there was a significant impact when persons had one or more health-related social needs. So if they had multiple health-related social needs, then putting those persons in an assistance track where we had tried to address their health-related social needs had a huge impact on total cost of care, inpatient admissions, and unplanned readmissions. Next slide. So here I want to spend some time really talking about the resolution of health-related social needs. The hypothesis for the accountable health communities model was that the initial hypothesis going in was that these participating sites would screen for health-related social needs. They would then assist persons with addressing their health-related social needs. And the hypothesis was that when those health-related social needs were resolved, then there would likely be an impact on total cost of care and a reduction in readmissions and unnecessary admissions. What the data found that actually occurred is that the majority of persons did not have their health-related social needs resolved within a year of receiving social care navigation. Now, there's various reasons for that, one of them being that the model did not pay for addressing health-related social needs. But despite the fact that the majority of persons, only 20% had all of their health-related social needs resolved, and 38% had one or more of their health-related social needs, the data still showed persistence in reduction in total cost of care and unplanned readmissions, even if their health-related social needs were not were resolved. And so what that finding is showing is that pairing persons with a team that's actively helping them to address health-related social needs, improve social cohesiveness, linkage to care, and still resolving issues that would likely lead to increased utilization, unnecessary ED utilization. So this proof positive that a reimbursement or compensation model to pair persons with health coaches and navigators to help them address health-related social needs has a statistically significant impact in reducing unnecessary utilization, even if the actual social needs are not fully resolved. So that was an unexpected finding. And since the data set was so significant, it's not that this is like an anomaly. And we had a small data set of 10, 20 people in a pilot. We're talking about 1 million participants. Next slide. And so now that we're seeing that this connection and linkage to resources has a direct impact on utilization, I want to also point out the data about the post-discharge follow-up, because I think this is a significant finding that correlates with the data from the accountable health communities model. Next slide. So this is a very recent article that was posted in JAMA that provided an analysis of the data. And they did a cross-sectional interrupted time series study of over 77 million Medicare discharges from 2010 to 2019. So again, a very significant data pool where they looked at assessing timely primary care or specialty care follow-up after an inpatient discharge. And we all know that timely follow-up after discharge will likely lead to improved health outcomes. Some of the, not included in this study, but some of the experience we found really at looking at some of the readmission data and issues causing readmissions. If you look at like some of the causes of readmissions for pneumonia, and I'll take that one as an example, in some of the markets that we were supporting, a lot of persons that readmitted to the hospital after an admission for pneumonia, many cases, they did not fill their antibiotics after discharge. And interviewing some of those consumers, a lot of the causes were the discharge prescription they were given by the hospitalist was non-formulary for their Part D plan. And then when they went to the pharmacist, they could not afford the out-of-pocket expense. When they went home, what likely happens if they call back to the hospital and say, I couldn't fill my prescription? The hospitalist says, you need to follow up with your primary care. And so that's one of the things I want to point out in the data where it shows the inherent failures in the system that leads to high utilization. And this also has a direct connection to screening and addressing health-related social needs. Next slide. So the data from this, and then again, the data set is over 77 million eligible discharges that were evaluated. It showed that the data showed that about 30% of Black and Hispanic Medicare beneficiaries received timely follow-up care after discharge. So 70% did not. So 70% of the data pool of Black and Hispanic Medicare beneficiaries did not receive timely follow-up of the discharge. If I take that last example of, that's very common, a person discharged with an antibiotic prescription for pneumonia and then calls the hospitalist who says, follow up with your primary, where 70% of that population is not getting timely follow-up after discharge, where is that person likely going to have their pneumonia addressed? In your emergency department. That's where it's going to happen, and it's going to lead to unnecessary follow-ups. And so this data is very significant. I also want to remind you, in the accountable health communities data, it showed that the greatest impact on addressing social needs occurred for which population? Black and Hispanic Medicare beneficiaries had the greatest reduction in total cost when their health-related social needs are addressed. And someone put in the chat, what does timely follow-up mean? Timely follow-up was looking at, did a person have a post-discharge follow-up within 14 days of discharge from an acute care hospital. And that aligns with the transitional care management benefit, where there's additional reimbursement, actually significant additional reimbursement, when a person has follow-up within 7 to 14 days post-discharge, which, if I take that pneumonia example, if I see that person within 7 to 14 days of discharge, discover that they were not able to fill their antibiotic prescription, and then put in an alternative intervention, I likely will prevent that person from winding up in the ER with a raging pneumonia because they simply couldn't fill their prescription. Next slide. Again, the data, dual eligible beneficiaries were the least likely to have timely follow-up after discharge. And so this is really concerning because dual eligibles are fully insured. So it's totally not an insurance issue. What are the contributing factors? Transportation, lack of access to primary care, like a lot of these things that are easily resolved. This group had the least ability to have timely follow-up, even though they're fully insured and there's reimbursement for this. And now there's reimbursement for addressing their social needs. And again, the data from the Accountable Health Communities model said if we screen and address social needs for dual eligibles, we're going to have the greatest reduction in utilization and reduction in unnecessary ED visits and readmissions. And so this group, there should be hyper-focus, but unfortunately, 70% of them are not getting timely follow-up post-discharge. Next slide. Populations that have the greatest social deprivation, so they have the greatest likelihood of having social needs, also had the least likelihood of timely follow-up. So again, I got about 70% of populations who have the highest likelihood of having social needs have the least likelihood of having follow-up. And again, this population, if we screen and address their health-related social needs, the data shows we're going to have the greatest impact in reducing overall utilization, and most importantly, unnecessary ED visits and unnecessary readmissions. Next slide. And so now I'm going to provide a example of the application of utilizing concurrent billing and really pulling together the data we just reviewed in the accountable health community model, as well as the retrospective analysis of over 77 million discharges, looking to see who exactly is receiving timely follow-up. Next slide. So in this concurrent billing case study, this is a dual eligible, admitted from a short stay SNF admission with complications related to diabetes, also with a complicating condition of homelessness. The concurrent interventions deployed: transitional care management, chronic care management for 1 hour, community health integration to address their homelessness, and there was 3 hours. So this all occurred during the same episode of care, 1 month, 30 days post-discharge from an acute admission. Next slide. So I'm going to spend some time here walking you through this process flow and really correlating this process flow back to the data that we just looked at from the Accountable Health Communities model, as well as the JAMA cross-sectional study looking at 77 million discharges. So if we're going to start at the top left-hand corner where the process flow is also numbered. So we're going to start with number 1. So again, this person had an inpatient admission with a positive health-related social need when that health-related social need was homelessness. If you remember back to the start of this ECHO series, we informed you that now CMS, in the inpatient prospective payment system rule changes, they now acknowledge that homelessness or housing insecurity as a complicating condition of an admission and now eligible for additional reimbursement. And so that additional reimbursement of the complicating condition being housing is about 3.1% increase in reimbursement to your hospitals when you simply code and add that this person has homelessness as a complicating condition. So in this admission, the admitting diagnosis was diabetes, the complicating condition was homelessness, which now it makes the hospital eligible for increased reimbursement because the MSDRG 638 is a diabetes admission with a complicating condition, that complicating condition being homelessness. The eligible ICD-10 codes confirming homelessness are the 3 that are listed there, Z59.00 to Z59.02. So you see it includes homelessness, sheltered homelessness, and unsheltered homelessness makes this person eligible for the complicating condition and increased reimbursement. So that's at the hospital level. Now, we're moving from section 1 to section 2, where the discharge planner schedules this person for a transitional care follow-up visit with a transition clinic. This person is dual eligible. And remember, based on the JAMA study, it showed that 70% of dual eligibles don't have timely follow-up. So in this example, where could the discharge planner connect this person to for follow-up? So that follow-up clinic, I gave some examples. You could consider many hospitals have established a resident clinic if they have a residency program. That could be a place. And next, some institutions have set up transitions clinic, heart failure clinics, partnerships with federally qualified health centers or rural health centers, home-based primary care. We're seeing more and more growth of home-based primary care. In some instances, I work with some institutions where they set up a nurse practitioner clinic or a chronic disease clinic. All of these could be eligible options for that TCM follow-up, transitional care management follow-up, that would be timely follow-up care post-discharge. Sometimes when I'm working with facilities and they have a concern that, well, will we be competing with the landscape of primary care? Well, the data looking at over 77 million discharges, the population is not getting follow-up. So we're really it really should be seen as an extension of their acute admission and not a competition with primary care, where now we can make sure that person has their post-discharge fill-up a visit within a timely manner. We can address any issues related to medication compliance or social needs that impacted that discharge, particularly since the hospitalist in most cases was the ordering physician for their follow-up care. And in a lot of markets, the primary, if there is a primary, is unaware of what the hospitalist orders were. And so now by establishing a transition clinic model, we can intervene to address any needs that will cause a likely unnecessary follow-up. And we can identify their social needs that complicate their follow-up plan. So that discharge planner connects that person. Now, using concurrent billing, you see the little money bags. That's just a way of showing where billing occurs. So in the clinic setting, the physician, nurse practitioner, or physician assistant does a transitional care management post-discharge visit. And in order to coordinate their care, they also implement chronic care management services. And the current rules allow for transitional care management and chronic care management to be billed concurrently. So both services could be provided to the beneficiary during the same episode of care, and both would be reimbursed. One caveat, they could not occur on the same day, but they can occur during the same episode, which would be a 30-day follow-up post-discharge from an acute admission. And so during that same visit, there's a screen for health-related social needs. In this example, the health-related social needs is homelessness. And so now that physician, nurse practitioner, physician assistant makes the referral for community health integration services. So now we're going across to number 4, item 4, where community health integration is used to address the housing issue. Item number 5, which is the bottom left-hand side, is where community health integration services are delivered by auxiliary staff to the transition clinic. That auxiliary staff can include community health workers, health coaches, social workers, or others. In addition, the final rules that from CMS allowing community health integrations specifically spell out that providers can contract with community-based organizations to deploy these services. We're going to see a great example of that after I present in Dothan, Alabama, from Sarcoa, that's implementing this model for a population of need where they contracted with a community partner. The rules specifically allow that. And so the last number 5, the billing codes I list there, and I'm going to show you what that reimbursement is. But I want to touch on one thing. A model where the transition clinic has community health workers that initiate addressing health-related social needs and then transition that person to a community partner to extend the labor addressing health-related social needs is also allowable. I want to note that in the accountable health community model with over 1 million participants, they worked with those participants to address their health-related social needs for over a year. So it's not likely if I have a transition clinic or if I have community health workers that are hired by my hospital, that they're going to follow everybody for a year or more. But the data shows, particularly when you're looking at complex social needs where people have 3, 4, 5 social needs, it may realistically take over a year to address all their needs. So the billing allows for concurrent billing and the aggregate of time spent, which means that if I have community health workers that are hired by the hospital and deployed to the transition clinic, and I partner with a community-based organization, and they're both providing interventions to address health-related social needs for the beneficiary, when we do the billing, it's the aggregate of time. So the time of the embedded community health workers that are hired by the clinic and the community-based organization working together to address the health-related social needs are billable. Both would be billable as the aggregate of time. So it's not an either or. It's who has the best ability to address the needs and where should we establish those handoffs. And that's where establishing a process flow that we develop with our community partners, like you're going to see later with Sarcoa, is an essential part of the process. But the leveraging the concurrent billing rules and the rule allowing for the aggregate of time, we're combining the labor of more than one person addressing the social needs is a strategy to make this completely sustainable. And so we're going to go to the next slide where I'm going to quickly talk about the reimbursement. So if I look at the financial model, and this financial model, I'm going to go line by line really quickly. Obviously, the MSDRG is the hospital admission. And so that MSDRG, that 638, is for diabetes with a complicating condition. The complicating condition is homelessness. And for the first time, CMS is recognizing homelessness as a complicating condition, and the hospital that reports homelessness is eligible for additional reimbursement, which on average is about 3.1% increase in reimbursement just by reporting homelessness as the complicating condition. That average reimbursement is about $5,000. Now, the discharge planner connecting that person to a transition clinic and that follow-up within 7 days is another $279 for the transitional care management timely follow-up within 7 days. Chronic care management to provide care coordination around their medical needs is also reimbursable to the transition clinic and allows for concurrent billing along with transitional care management. In this example, there was an hour, and so the reimbursement would be the $62.58 plus an additional $95.86, which represents an hour of chronic care management. And then lastly, the bottom two codes is for community health integration to address the social need of housing insecurity. And in the model example, it was an example of 3 hours deployed to address their health-related social needs, which then brings in an additional reimbursement of $281. So the grand total for the hospital admission and the post-discharge follow-up for the first 30 days is about $5,900. So when I talk with groups and they're saying, you know, we're grappling with how to make this sustainable, I grapple with how you can't make it sustainable. I mean, I really think this is a viable model to really deploy intervention to address health-related social needs and to extend those interventions into communities with community partners. And then next slide, it's my last slide, and I'm gonna turn it over to the team in Alabama. So this outpatient revenue analysis, if I look at the transitional care management, again, with the vast majority of the population not receiving timely follow-up and not getting that 7-day follow-up. So the transitional care management reimbursement, the national reimbursement is $279. If I compare that to a new patient E&M visit for a level 3 E&M visit, that reimburses at $111. So the comparison, if I have a tight transition model where we're partnered with community health workers that are addressing transportation and other things to get that person back to a transition clinic for timely follow-up, we're talking about a difference of about $180 that we're leaving on the table for the most vulnerable population if we just coordinate the transition better. There's additional reimbursement that we're leaving on the table. And so again, when I hear groups saying that these models are not totally sustainable, it's not sustainable not to do it because there's too much money that's being left on the table to do good, right? To really address the needs that the data shows this group has the most needs. And then lastly, concurrent billing of CCM and addressing their CHI for an hour of chronic care management that can be billed concurrently with transitional care management. That brings in another $158. And then 3 hours to address their health-related social needs with a health coach or community health worker. That brings in another $281. So just for coordinating care during the first 30 days after a discharge, not even including the provider revenue, that's another $440 that now is on the table to address their needs and coordinate care. And so that it really isn't an issue where we're looking at, if we bring on a community partner or we bring on community health workers, where are we taking away revenue to finance that model? It really is now, if we're bringing that on, we're also